So continuing with the respiratory system, we're going to start looking at the physiology of the respiratory system. So the respiratory system has some processes to do because it's about exchanging gases, but you have to get the gas, the air, from in front of your face into the alveoli, into the respiratory zone. And you have to get the old air that you've extracted the oxygen from and added the carbon dioxide back out. So that you need that gas exchange, and that's called pulmonary ventilation. You need that gas movement. So you're ventilating. Then in the alveoli, you have to have the exchange of the oxygen to the blood and the carbon dioxide from the blood. And we call this external respiration. And then the blood has to carry the gases between the lungs and the tissues. So carrying carbon dioxide from the tissue to the lungs, carrying oxygen from the lungs to the tissue is gas transport. Now that's really not part of the respiratory system, it's part of the cardiovascular system, but nevertheless it has to happen. Then we have to have internal respiration. We have to get the oxygen out of the blood and into the tissue cells, and the carbon dioxide out of the tissue cells and into the blood, and that's internal respiration. So we need to have this for ventilation, which is the first thing we're going to talk about. We need to move the air containing oxygen inhaled into the lungs, right? Then oxygen into the pulmonary capillaries, transported to the cells, diffusing from the capillaries into the cells, picking up the carbon dioxide from the cells, transporting the carbon dioxide, bringing that to the walls of the capillary and the alveoli, putting it in the air and exhaling it is what has to happen. And this is, again, breaking it down, kind of the 8 steps of that. Okay, the colloquial term for pulmonary ventilation is breathing. Inspire brings air into the lungs, inhalate. Expiration or exhalation is forcing air out. A couple of other definitions. Eupnea is quiet breathing. That's just rhythmic at rest breathing where you're not working really hard. Forced breathing is more vigorous, and you have to work harder for that. If you're blowing up a balloon or something, it's forced exhaling. If you're taking a conscious deep breath, it's forced inhaling. There are places in the brainstem that control the rate and depth of this. And there's skeletal muscle, there's voluntary muscle that are going to change the volume of your thorax and really cause breathing. Because volume changes are going to result in pressure changes, and pressure changes is what moves the air. Air moves down a pressure gradient. It moves from areas of high pressure to areas of low pressure. So inspiration, when you're breathing in, you are making the pressure in the lungs lower than atmospheric pressure, and the lungs inflate. You increase the pressure in the lungs above atmospheric pressure, and you exhale. So there's a whole bunch of muscles involved, mostly the intercostal muscles. The diaphragm is the most important one. There's some other accessory ones like the serratus posterior superior and inferior, some of the erector spinae muscles, but mostly the the sternocleidomastoid, the scalene muscles are all involved. The abdominal muscles can be involved, but whatever. Okay. The thoracic volume, the space within your thorax, will change. And it's because your ribs are like bucket handles. So if you lift the ribs up, pivoting them on the spine, then the space between the sternum and the spine will increase, and therefore increase the volume of the thorax. The diaphragm also is domed up when it's relaxed. And as you tighten it, it flattens out. It moves more towards the abdomen. It's like a blanket toss upside down. You tighten it, the curve goes away and it becomes flatter. When you relax, the diaphragm domes back up. So tightening it actually increases the thorax, which will decrease the pressure. That's all you need for relaxed breathing. You just need the diaphragm. You don't really need the other muscles that move the thorax. If you're taking deeper breaths, you need to be moving your ribs more. So lateral A to P, so changes. So inspiration, the thoracic cavity gets bigger. Expiration, the thoracic cavity gets smaller. The diaphragm goes down. Inspiration, the ribs widen and the sternum moves forward and up. Expiration, the diaphragm bulges up, the sides contract, and the sternum and ribs move down, decreasing that space. Boyle's law. Boyle's law basically says if volume goes up, pressure goes down. And if volume goes down, pressure goes up. It's, every kid that's ever stepped on a ketchup pack at McDonald's knows that. Every teenager that's ever popped a pimple knows that if you make the volume go down, the pressure in the pimple goes up. I think it's wonderful that Boyle's law is popping a pimple. Now, he's represented it as that pressure and volume are inversely proportional, and that so pressure 1 at volume 1 is always equal to pressure 2 at volume 2. So when one goes up, the other one goes down. So really, we're going to be talking about pressure gradients. So the greater the pressure gradient, the faster the flow is in between until the pressure equalizes. It really is a straightforward concept. A lot of pressure in one area, less in the other, and it equalizes. So how do we control breathing? How do we know when we have to breathe? There are chemoreceptors that monitor changes in hydrogen ions primarily. We're also looking at the partial pressure of carbon dioxide and the partial pressure of oxygen as well. But the primary thing is the pH, the hydrogen ions. So there are central chemoreceptors right in the brain, the brainstem, that look at the pH changes. And because carbon dioxide is in the blood mostly as carbonic acid. It's the acidity that's caused by the excess carbon dioxide that we're looking at. There's also peripheral chemoreceptors, especially in the aortic and the carotid bodies. And again, they're going to respond to acidity in the same way. Now, unfortunately, carbon dioxide isn't the only source of acidity. So we're going to see later in the semester, when we look at acid-base balancings, that it's tied in with the respiratory system. There's also some irritant receptors and some baroreceptors, so stretch receptors within the alveoli of the lungs and the bronchi. There's also proprioceptors in the joints and in the muscles, so that if you start using those muscles, your body anticipates that there will be a bigger need for oxygen, and so therefore it increases breathing. So normally you're trying to get rid of carbon dioxide. When you get rid of carbon dioxide, you make the blood less acidic. So ventilation increases when things are acidic. Because of that, the partial pressure of carbon dioxide is the most important stimulus to affect breathing. Let me reiterate that. The most important stimulus for breathing is the amount of CO2. If you want to spend time underwater, if you want to dive, if you want to free dive, most people think that you take a big lung full of air with lots of oxygen in it, and then you try and hold that so that your blood can pick up oxygen even when you're not breathing. But it doesn't work that way. The amount of oxygen, the partial pressure of oxygen, is not that high for that to have an effect for a very long time. The way to hold your breath longer is to blow off the CO2. So you're actually better off exhaling, getting rid of CO2, and keeping your pH normal if you want to stay underwater longer. So it's letting that carbon dioxide go, because those receptors are the most sensitive to that. The joint and proprioceptors I just already talked about, the stretch receptors in the pleura and the bronchi. Then there's irritants for sneezing and coughing, etc. So a concept that comes around a lot is that flow equals the difference in pressure over the resistance. In electricity, that's called Ohm's law. Current equals voltage over resistance. In blood flow, it's blood flow equals the delta P over the resistance of the cardiovascular system. In airflow, flow equals delta P, the pressure gradient, over the resistance. So flow is directly correlates with pressure. So the greater the pressure gradient, the greater the flow. And it's inversely proportional to resistance. The greater the resistance, the less the flow. So F equals delta P over R. If the pressure gradient increases, airflow increases. resistance, it decreases. And we're constantly having a balance between these two factors. So because of Boyle's law, we know that we can decrease the pressure in our thorax by expanding the thorax. If it goes below atmospheric pressure, air will enter the lungs and the lungs will inflate. If you make the thorax smaller, the pulmonary pressure, the intrapulmonary pressure, goes above atmospheric pressure and you breathe out. So changing the volume of the thoracic cavity affects the pressure gradient. Now the resistance has a couple of factors. The elasticity of the chest wall and the lungs. So that's the compliance of the lungs themselves. The harder it is to expand, then the harder it is to fill it with air. The size of the lumen of the bronchiole will affect resistance. So small, like bronchoconstriction, you get more resistance. Or the alveoli could just collapse, and in which case it's very difficult. So chest wall elasticity was going to decrease with arthritis, with scar tissue, pulmonary fibrosis. My father passed away from pulmonary fibrosis, and that's his lungs. The elastic tissue was replaced with scar tissue, and the lungs just wouldn't expand. So the volumes of air that he could move went way down. Bronchial diameter. Bronchoconstriction increases resistance, bronchodilation decreases. Things like the sympathetic nervous system, epinephrine will cause bronchodilation. Bronchoconstriction can be excess mucus, or it can be parasympathetic, or it can be inflammation, anything like that. If the alveoli won't expand, then there's a lot of resistance. Compliance is a word that I've just used. It's the ease with which the lungs and chest expand. If it's easy, it's compliant. If it's not easy, there's less compliance. There's this idea of surface tension and elasticity. If the elastic is too strong, then you have less compliance. If there's too much surface tension, it decreases compliance as well. So, decrease in compliance, decrease in the size of the lumen. You need to work harder to bring breath in. Now, inspiration is an active thing. You have to actively work at it. Expiration is normally passive. You just stop breathing in, and then the elasticity pushes the air out. But if there's more resistance, you might actually have to force the air out. So people with COPD and things use a lot more energy to breathe out. Breathing in, probably not much different, but it's exhausting. We will talk about volumes and rates and that in the next video.